So, in this video, we will be talking about parenteral nutrition. So, first, let us understand why nutrition is important for a surgical patient. One is due to decreased intake, and second would be due to increased requirements due to disease. And hence, nutritional support is needed to prevent malnutrition and to treat it. So, we have various tools to screen for malnutrition, one of which is the MUST tool, which is the Malnutrition Universal Screening Tool. So, this assessment will be done on admission and at regular basis during the course of hospital stay. In case we find that there is an increased risk of malnutrition, then we have to go ahead with a thorough assessment of the nutritional status of the patient. So, the MUST tool is a 5-step tool in which step 1 is assessment of the BMI. Based on the BMI, we score the patient. So, any patient having a BMI of more than 20 would have a score of 0. 18.5 to 20 would have a score of 1, and less than 18.5 would have a score of 2. The next step is assessing unplanned weight loss. Over a period of 3 to 6 months. So, if it is less than 5%, the score assigned is 0. 5 to 10%, the score assigned is 1. Now, the third step is to assess decreased nutrition intake. Now, the next step is to assess acute illness along with decreased nutritional intake. If present for more than 5 days, is given a score of 2. Now, the step 4 is to add all the above scores. Uh, is to add the above all scores of BMI, the unplanned weight loss, and the effect of acute illness and decreased nutritional intake. So, following this, we get 3 classes. One is if the total score is 0, it is assigned as low risk. If the score is 1, it is medium risk. If the score is more than equal to 2, that is labeled as a high risk patient. And step 5 would be to manage. So, low risk patient would go ahead with routine clinical care. In a medium risk patient, we have to observe and intervene when necessary. And in a high risk patient, we have to formulate an action plan to improve the nutrition of this patient. So, based on the MUST tool, we have identified several factors which indicate nutritional support. Now, this nutritional support can be either enteral or it can be parenteral. So, a patient with very high risk of malnutrition, that is one BMI of less than 18.5, weight loss more than 10%, and suboptimal intake. Would require a nutritional support, and it should be considered in patients with BMI of less than 18.5, weight loss of 5 to 9% over 3 to 6 months, and a moderate or a mild loss of fat. Now, let's move ahead with the indications for parenteral nutrition. So, one is if normal oral or enteral nutrition cannot be started for 5 days. This patient requires a cover with parenteral nutrition. Second is when the gastrointestinal tract is either non functional or leaking, cannot be accessed, or can't be adequately nourished. So the examples of each one of these is non-functional or leaking could be obstruction, ileus, or a fistula. Cannot be accessed in cases of intractable vomiting where jejunal access cannot be established, and can't be adequately nourished in cases of short bowel or radiation enteritis. Now, one thing to note in this case is that even small amounts of enteral nutrition is useful as it stimulates normal intestinal functioning. So, so whenever feasible, this patient should be shifted to enteral nutrition, or there should be a cover of enteral along with parenteral nutrition. So, next, moving on to the nutritional assessment of an adult patient. Now, the purpose of performing a nutritional assessment of an adult patient is to identify the nutritional status and to identify the nutrient and metabolic risks. So, we have various tools for performing the nutritional assessment of an adult patient. Uh, I'll be listing a few of those. First is clinical. So, clinical entails your history. For example, a history of major abdominal surgery or sepsis would account for metabolic risks or the nutrient risks in that patient. The gastrointestinal factors, which we have discussed earlier, such as non-functioning bowel, bowel which cannot be accessed and cannot be adequately nourished. Physical examination. So, physical examination can give an assessment based on the appearance, the presence of subcutaneous fat, pallor, muscle wasting, or vitamin deficiency features like angular stomatitis and bleeding gums. Next, we can go ahead with anthropometry, wherein we assess the BMI of the patient, the unintentional recent weight loss, and the trend in the weight, whether the patient is gaining weight or losing weight or has been stable throughout. Body composition. We can assess this via mid arm upper circumference and skin fold thickness. Following this, we can also take a functional status of the patient. Uh, for example, the immune function, the muscle strength, etc. So we have first identified the indications of parenteral nutrition and how we assess the nutritional status of the adult patient. Next, we will understand how we give this parenteral nutrition. So the venous access for parenteral nutrition in an adult patient. So few things. The choice for the site of the venous axis depends on multiple factors such as the risk which will be associated with the placement, the ease of care, the duration, and the complications. So we have two choices in such a case. One is the central axis, and the other is a peripheral axis. So a basic understanding is that a central axis is needed when we think of a long-term parenteral nutrition requirement, and a peripheral axis is required for short-term parenteral nutrition requirements such as 10 to 14 days. Now, first, let us discuss the central axis. So, parenteral nutrition has increased osmolarity, and increased osmolarity will lead to increased thrombosis, and hence the central line is preferred for increased osmolarity parenteral nutrition. The choice of veins could be a subclavian, internal and external jugular, and femoral. And the placement is such that the tip should lie at lower one third of superior vena cava and atria caval junction. If in case the superior vena cava is contraindicated, then we can go ahead with the inferior vena caval axis. So a chest X-ray would be required to confirm the position of the tip in cases where we have not confirmed during placement via an ultrasound. If we have gone ahead with a blind approach, and if there is a history of prior use of catheter. So based on this, we have three kinds of central axis. One is the non-tunneled and non-cuffed. Next is the peripherally inserted central catheter. And finally, we have the tunneled kind. So a non-tunneled, non-cuffed catheters are appropriate for short-term use, and they are associated with the majority of catheter-related bloodstream infections. And second, we have the PIC line. So a PIC line is when a central axis is indicated and the exit site is on arm. The rate of infection in a PIC line is lower when compared to a non-tunneled, non-cuffed catheter. And finally, we come on to the tunneled catheters. So they follow tract under the skin before entering the central vein. And these are most common for long term. Why? Because they're associated with the least infection rate. So next, moving on to the peripheral venous axis. Peripheral venous axis, one thing to note is that they require frequent rotation due to thrombosis. And second, the fluid should be of lower osmolarity. Next, coming on to the types of peripheral catheters. So we can have a Teflon catheter and we can have midlines. So a midline has its exit into the basilic or the cephalic vein that is in the arm with the tip in the axilla. So a Teflon or a normal cannula would require an osmolarity of less than 700 milliosmoles to prevent damage to the vein endothelium and thrombosis. And a midline can tolerate up to 900 milliosmoles per liter. However, they require continuous infusion at a rate up to 120 ml per hour. So next, coming on to the care of these lines, be it central or peripheral. First, we need to perform absolute aseptic technique while handling these lines. And if it is a single lumen catheter, it needs to be a dedicated line for the parenteral nutrition. Next, it should not be stopped for diagnostic or interventions. For diagnostic purposes or for interventions. Next, to minimize the risk of catheter infection, we can follow certain practices like a single lumen catheter, preferably a PIC line or a tunneled catheter, USG guided punctures to prevent multiple puncture sites, and education about the care of these catheters, hand wash prior to handling these, use of 2% chlorhexidine, exit site dressing, and monitoring the exit site to assess early signs of infection. So now we have discussed the indications of parenteral nutrition, how to assess the nutritional status of a patient, and the venous axis, which is required for a parenteral nutrition. Now let us discuss the parenteral nutrition requirements. That is, at what rate or what amount it should be transfused to a patient requiring parenteral nutrition. So, the first step prior to starting a parenteral nutrition is to consider the risk of refeeding. So, we have various factors which help us to assess this. We have one high risk patient, and we have a medium risk patient. So, a high risk patient, if any one of the above is present, this automatically makes this patient a high risk for refeeding. That is, if the BMI of the patient is less than 16, if there is unintentional weight loss of more than 15% within 3 to 6 months, no oral intake for more than 10 days, and already the patient has low levels of potassium, phosphate, and magnesium prior to prior to starting the parenteral nutrition. So any one of these would make the patient at a high risk of refeeding. Next is the medium risk. If more than two of these factors are present, that is BMI of less than 18.5, weight loss in this would be more than equal to 10% within 3 to 6 months, no oral intake for more than 5 days, and use of drugs like insulin, chemotherapy, diuretics, or a patient is an alcohol abuser. Now, if any two of these factors are available, it would again make the patient at again make the patient a high risk for refeeding. So, how do we start the nutrition in these patients? There are certain guidelines. First, we always start with 10 kilocalories per kg per day for 24 hours, and then increase the infusion rate slowly to reach the goal rate within 4 to 7 days. Within 4 to 7 days. Biochemistry of these patients should be monitored twice a day. Thiamine is added in the parenteral nutrition of these patients at 200 to 300 mg daily prior to starting the parenteral nutrition, as well as up till 10 days of nutrition, up till 10 days of infusion. Supplementation of electrolytes, that is IV of potassium 2 to 4 millimoles per kg per day, of phosphate 0.3 to 0.6 millimoles per kg per day, and magnesium 0.2 millimole per kg per day IV is required if not already raised. So these steps would prevent refeeding in a patient who is at a high risk for refeeding, that is starting at a lower rate of infusion, which is 10 kilocalories per kg per day for 24 hours, and then you reach the subsequent goal rate in the next 4 to 7 days, monitoring the biochemistry of such patients at least twice a day, adding thiamine to the infusion at least 200 to 300 mg daily prior to infusion and up till 10 days of the infusion, supplementation with the electrolytes if it is not already raised. So, this is for a patient who is at a high risk for refeeding. Now, let us consider patients who are not at a high risk for refeeding. So, the requirements of such patients: first, coming to the energy. So, every patient's energy requirement would be different considering the different stress and the different procedure that has been done. But a safe starting point would be 25 kilocalories per kg per day, with a maximum of 35 kilocalories per kg per day. Now, for obese patients, we use the adjusted weight, which is actual weight minus the ideal weight divided by 2, and add the ideal weight. So the ideal weight would be calculated via the Hamvey equation. For a female patient, it would be 45.4 kg for the first 152.4 centimeter, and subsequently we add 2.27 kg for each 2.54 centimeter. And in cases of males, it is 48.1 kg for the first 152.4 centimeter, and we add 2.72 kgs for each 2.54 centimeter. So, so this is the energy requirement. Next, moving on to the protein. So there are no strict guidelines for the protein requirements. However, a safe initial starting point can be 1 to 1.5 grams per kg per day, with a maximum of 2 grams per kg per day. Next, moving on to carbs. So the preferred source of carbohydrates is glucose, and the maximum capacity to oxidize glucose is 6 mg per kg per minute, which accounts to 35 kilocalories per kg per day by glucose. So we should not exceed this rate, as exceeding this would lead to certain complications like hyperglycemia, fatty liver. Next, moving on to lipids. So the lipid component is mainly phospholipids and triglycerides. So this is better given in a 3-in-1 parenteral nutrition preparation. So I'll be discussing what that is in a little while. And it is better given slow, as rapid infusion of lipids leads to lipemia and clearance by reticuloendothelial cells, which leads to liver dysfunction. Now, the dose of the lipid is at 1 gram per kg per day while monitoring for lipemia, with a maximum of 2 gram per kg per day. In cases of severe liver or renal dysfunction, you do not exceed 1 gram per kg per day. So ideal is a continuous infusion over 24 hours, as we have discussed that rapid infusion leads to lipemia and clearance by reticuloendothelial cells, leading to liver dysfunction. So there are various types of parenteral nutrition. One is a 2-in-1 solution which contains glucose and amino acids, and the other is a 3-in-1 solution which we discussed earlier, where we have glucose, amino acids plus lipids. So this is more common, and there are various advantages of 3-in-1 solution, like it is readily available, stable, easy to use, and time saving. So in cases of central line, so in cases of 3-in-1 solutions which are prepared for infusion via the central line, the average lipid is 30 to 50%. Now it is beneficial as the energy via glucose would be reduced, and therefore it would take care of complications like hyperglycemia and fatty liver. But the infusion via the peripheral line would contain lipids anywhere between 40 to 60%, and this is done so that the osmolarity of the solution is reduced, and this minimizes the risk of thrombosis. Now, coming to the limitations of parenteral nutrition, first would be the storage. So the storage requirements of parenteral nutrition is 2 to 8 degrees Celsius. This is a strict standard, as any lower than this would lead to lipid solution being frozen, and frozen lipid becomes fatal as lipid emulsion cracks in result and results in fat embolus. Next would be light protection. It is light protection is important as it contains vitamin A and E, which are light sensitive, and lipids undergo oxidation when they're exposed to light, and hence a parenteral nutrition solution needs to be covered or protected from light when infusing. And next, coming on to the hang time. So maximum hang time of 24 hours, beyond which the solution should be discarded. However, if it is a standalone lipid emulsion, a standalone lipid emulsion has a maximum hang time of 12 hours, beyond which it should be discarded. So now let us come to the monitoring of a patient on parenteral nutrition. So we have the monitoring when the initial parenteral nutrition is started and once the patient is stable. So first, the nutritional intake, whether it suffices or it is enough to meet the requirements of the patient. Initially, this assessment needs to be done daily, and once the patient is stable, can be done twice a week. Next, coming on to the fluid balance chart, that is the input output charting. This is done to assess the fluid status and to ensure that the patient is not over or underhydrated. Initially, it is done daily. Even when the patient becomes stable, this should be done daily. Next, moving on to the weight monitoring. This also helps to estimate overhydration and to determine whether the nutritional goals are being achieved. Initially, it is done daily. Later, it can be done 2 times a week. So, vital charting like the temperature, pulse, BP, and the respiratory rate should be done 4 hourly. Be it in the initial phase or even when the patient is stable, this should be done 4 hourly. Glucose monitoring of such patients is initially done 6 hourly, and later once a day would suffice, but it is important to monitor for hypoglycemia when you are trying to stop the parenteral nutrition uh, infusion. Next, moving on to sodium, potassium, urea, creatinine, magnesium, phosphate, LFTs. So initially it is done daily, later twice a week would suffice. Coming on to CRP. This is to assess the presence of acute phase reaction. So initially it is done twice a week, 2 to 3 times a week, once till it becomes stable, and then weekly would suffice. Moving on to the complete blood count of this patient. So initially done twice a week, later weekly. The cholesterol, that is the lipid profile of this patient, is initially done at baseline, that is prior to starting your parenteral nutrition, and then done weekly. Other trace elements other elements like your iron studies, folate, B12, manganese if available, and vitamin D, initially done on starting the parenteral nutrition and then done monthly. So these are the monitoring that needs to be performed in a patient who is on parenteral nutrition and the frequency of such monitoring. Next, moving on to the complications of parenteral nutrition. So first is the liver dysfunction, and we have discussed that the most common of this would be hepatic steatosis, cause being increased calories, specifically from carbohydrates, and secondly would be gallbladder and biliary complications, which would be cholelithiasis and cholestasis. So lack of enteral nutrition and long-term parenteral nutrition can lead to the formation of gallstones. So management of this would be to not exceed overall calories, initiate oral nutrition as early as possible, cyclic parenteral nutrition. So cyclic parenteral nutrition would allow fasting time to reduce the insulin levels and to help with liver dysfunction, and to always send blood cultures, because liver dysfunction could also be a sign of sepsis. And lastly, coming on to the cessation of parenteral nutrition. Whenever planning on stopping parenteral nutrition, you should always monitor for hypoglycemia. And it is important that we do not stop parenteral nutrition abruptly. We can reduce the rate to 50% of what we were giving earlier, continue this for 1 to 2 hours, and then stop. So this avoids the need for strict glucose monitoring after we stop the parenteral nutrition. So in this video, we have taken a look at parenteral nutrition, the need for parenteral nutrition, how we assess the patients who are at risk of malnutrition, the indications for nutritional support, be it enteral or parenteral, the indications for parenteral nutrition, that is when oral intake or enteral nutrition is not possible for 5 days, or GIT factors like non-functioning gut, or gut that cannot be accessed, or if a patient cannot be adequately nourished via oral nutrition. The nutritional assessment of the adult patient via clinical anthropometry, body composition, and the functional status. The venous access for a parenteral nutrition, which can be central or peripheral, and the requirement for each of these. We have also discussed how to minimize catheter infection and the requirements of parenteral nutrition, considering patients who are at risk of refeeding. And in other patients, we have also taken a look at the types of parenteral nutrition, that is a 2-in-1 and 3-in-1, the limitations of parenteral nutrition, and how to monitor the patient who is on parenteral nutrition, along with the complications and how to stop parenteral nutrition. If this video was helpful, do hit the like button, share, subscribe, and comment. Thank you so much for watching.